Hello class, this is Dr. Satish. Unfortunately, the video recording is not happening, um, and I'll be continuing the next of the trauma that has been left over. So last you I don't know where you were speaking, but today I'll be talking to you about an extensive topic of abdominal trauma. Abdominal trauma is one of the most important things that you will find uh, in your casualty postings, not in a busy setup. And it is important because a mildest of problem in the abdomen will cause serious consequences. So we have to be even more careful when we are dealing with trauma to the abdomen. What are the causes for abdominal trauma? There are two. One is penetrating injury, one is blunt injury. When do you see penetrating? When do you see blunt? Blunt injury is usually uh, when you have no piercing object getting into the abdominal cavity. Whereas penetrating injury is how much the depth of uh, the instrument has gone in. It could be accidental, it could be homicidal. Both of them, accidental, homicidal. So how will you deal with a patient when he comes to the casualty with abdominal trauma? What are the signs that you have to keep in mind that the patient has suffered from blunt trauma abdomen? Most of the times it's road traffic accidents, it is homicidal, I mean somebody punching you, somebody inserting a knife into your abdomen, and stabbing a knife into your abdomen, knife or a sharp object, or it could be anything that pierces the peritoneum. Once it pierces the peritoneum, it becomes inadvertent for us to consider the case as emergency. What is the most useful investigation to get to know about trauma to the abdomen? The most useful investigation, or the investigation of choice, is CT scan. You have to remember the CT plane. CT plane. If it is not possible, the patient is very very bad and you can't waste much time, then you will do something called as FAST. FAST is focused ultrasound of the abdomen. Focus ultrasound. I don't know what is the problem today. The video is not working. There's no light. I'm literally working in the dark. But yeah. So not trauma. FAST is focused sonar trauma to the abdomen. You will take 4 quadrants, that is suprapubic, that is hypochondrium, right hypochondrium, left hypochondrium, epigastrium. Epigastrium you want to see because there is the sheath that is separating the abdomen from your diaphragmatic sheath that is separating your heart, that is your heart from the abdominal cavity. So you have to understand pericardial region to know if there is a cardiac tamponade. Then you will do a right hypochondrium, left hypochondrium. Then you will do the suprapubic region or the pelvis, because most of the collection will go and collect in the pelvis. So this is what you should see. And then once you do this, these are investigations. That's what. So the patient has an injury, or the patient had a stab, or the patient has had a seat belt injury, and the most common organ involved in abdominal trauma, the number one is liver greater than spleen. Liver greater than spleen. So these are the two solid organs that you need to be careful about. careful about. In penetrating injury, it is your small intestine. Penetrating injury, it is the small intestine. For penetrating injury to be called abdominal trauma is to breach the peritoneum. It has to breach the peritoneum. Then only we consider it has uh, emergency. Otherwise, you will do close packing and nicely debride the whole region, and then you can suture. That is what you will do. It has to breach the peritoneum. It has to breach the peritoneum. Please remember, all these points are entrance point of view. Liver greater than spleen, then penetrating trauma if it has to breach peritoneum. CT scan is the investigation of choice. Fast, focused, and ultrasound of sonar trauma. Focus abdominal sonar trauma. That is basically you are going to, if the patient is unstable. And what is the most common injury of the seat belt? When the patient is wearing the seat belt, and he has had a road traffic accident, which is the most common organ that gets involved. It is the mesentery. There will be a mesenteric tear. There will be a mesentery tear. There will be a tear in the mesentery. So it is all how you will perceive things. Liver is greater than spleen. That gets most of the times damaged. Most common organ injury in blast is your eardrum. Please remember, this is another point that you should be remembering. It is your eardrum. Most common organ to get involved in your blast injury is your eardrum, followed by the lungs and then by the small intestines. Followed by the lungs, then small intestines. Then how does the patient come? He's bleeding inside. You don't know what is happening. How will you think, or how will you suspect a patient is having an abdominal injury? The first and the foremost sign that you should suspect that the patient has an abdominal injury is if the patient has, please remember the words, if the patient has a abrasion on the abdomen. If an abrasion is there on the abdomen, it is a clear sign that the patient is having a injury, or probably the patient is having a internal abdominal injury, unless and until proven otherwise. So these are the certain points that I wanted to tell you. And don't think if patient is wearing a seat belt and he is having a mesenteric tear, why should you wear a seat belt? Trust me, it is decreasing mortality and morbidity of abdominal trauma by 50%. Only because mesentery is getting teared, that does not mean it is going to cause a lot of problem. Okay, so these are the things that you should be remembering in general. Now we'll talk about how is the patient. Patient will come to you to the casualty. He will not be brought to you your OPD because he is sick. How do you recognize there is a problem? How do you recognize? The first and the foremost thing, the patient has come to you, he's lying on the casualty bed. So how do you think how do you think you're going to deal with this patient? This patient has to be dealt immediately. Why? Because something is missing. So you will do A, B, C, D, E. A, B, C, D, E. Just I have a call, guys. Hello, Siddharth. Yes, Siddharth. No, Siddharth. Right now I'm in a class. Exactly after 1 hour. No, you ask them to get a TV, so they'll get it sent to you. Treadmill test? No. TDSO is ultrasound. Yeah, without treadmill. I don't think your symptoms you're telling your mother will be able to do a treadmill. Yeah. So, yeah, how will the patient be? The patient will complain of pain, will the patient, do you think, will be in a state of pain? Yes, he will have pain, but unfortunately, please remember, he will have pain. Definitely the patient will have pain. But if the bleeding is massive inside, okay, if the bleeding is massive inside, there is no chance that the patient will be complaining of pain. He will be in a case of shock. What are the signs of shock that you guys already know? I already told you shock is taken initially by me. So the patient will have confusion. Okay, he is not in a proper mental state. He's completely sweating. His pulse is tachycardia, steady pulse. Steady pulse is one most of the times most common sign that you can elicit in a case of steady pulse. Then you will have low blood pressure. He's tachycardia. So the patient can tell of pain. He may localize the pain, etc., etc., but he will be in a state of confusion. That should clinch the diagnosis, and then you should see. If the blood pressure is about 110/70, 110/80, 120/90, then you will send the patient to a CT scan. If the pulse rate is about 110, 120, and his blood pressure is 90/60, there is no time that you will waste. There is no time that you will waste. You have to, at any cost, you have to send the patient to a fast, not send the patient. Ultrasound machine will come to you, maybe the sonologist. In fact, you guys should also know what are the features that are there in fast. So once you recognize the problem, you will do a full survey of the patient. That is A, B, C, D, E. A is airway, B is breathing, C is circulation, D is any deformity, and E is you have to check all this thing that's called as primary survey. These are the A, B, C, D, E. These once you see this, then you will do this is called as primary survey. In primary survey, once you find the patient is okay, then you will send him for the CT scan. That ends your primary survey. Then you will see a secondary survey. You will see if any limb has got damaged. You will see any other, like the lungs. You will see about everything. Again, that is called as a secondary survey. Once you see these, you will see all those to know if there is any problem. You will have to examine the spine. You have to examine the pelvis. These are the secondary surveys, not the primary. In primary, it is either beating circulation, deformity, and eye response. So once you have seen this, you have to think what is happening. How will you go about with managing? Because abdominal trauma in itself is a very, very big topic, and the multiple organs that will be involved, multiple these things are there. It will take some time for us to go in detail, and as the classes permit, we will be discussing more better in trauma only. So once the patient has you have examined, primary survey is done. If he's stable, you will send the patient to a CT scan. If he's not stable, you will do a fast. Once you have done fast, okay, there is a fancy for something called as diagnostic peritoneal lavage. You're not doing diagnostic peritoneal lavage anymore, okay? You're not doing any more diagnostic peritoneal lavage. What is diagnostic peritoneal lavage? Those days when there was no ultrasound or CT scan available, into the abdomen, just below or above the umbilicus, pierce the peritoneum and suck in about 10 cc of the content. 10 cc of the content. Most of the time, if it is a solid organ injury, it will be blood. Most of the time, if it's a solid organ, it will be Am I audible? I have a doubt. One before. Am I audible? Hello? 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 Am I audible? Okay. It's okay, it's okay. I don't think this is better. Uh, I will take minimal class today and we'll continue all that in the next class because when you can't understand anything, what is the use? So, yeah, once you see, once the survey is done, then you will subject the patient to, only I'll finish off, I mean, what are the things that you should do when a patient comes to you. Solid organ injuries and all I'll take in the coming classes when the audio and video and even the light, this place is so dark, I'm sitting in all alone in a dark place. This is not how the class to be conducted. So you have seen the patient, you have done a survey, then you have diagnosed solid organ injury or what and what and what. That is afterwards. The patient comes to you. So first, what are the things that you will do? You will see for airway. So how do you check for the airway? Jaw thirst, chin up, jaw thirst. So, and you put a Goodell's apparatus so that the patient does not have anything that is obstructing his airway. Anything is obstructing his airway. Then you will check for breathing. Breathe. What is his breathe? Is he taking normal breath, shallow breathe? Is it technique? Then you will see for the surgery. Most of the times, as I said, you will have steady pulse. Steady pulse is the most important thing. If you see all this, the first and the foremost thing that you're going to do is create an IV line. Okay, create an IV line. IV line has to be created. Okay, create an IV line, and the IV line that is recommended in these days is a grey colored cannula. Grey colored cannula. Please remember that is for I think it is 16 gauge. It's not 14, 16 gauge. 14 gauge is orange color. 16 is grey color. Grey color you have to give because you have to give large doses of fluid. So when you have to give bolus, you cannot be giving in the cannulas numbers of 18, 10, 20 and 22, which is pink and blue. You can give it in green, but ideally it should be grey colored cannula. Immediately you start bolus of 200 ml as I told you in the shot, and then they run about 100 to 120 ml per hour. 100 to 120 ml per hour. You will check this, then you will check for the deformities. You will check for the deformities. In this all this while, you have to give the warning, or you have to ask the people to get ready with blood. Blood products. Blood products. Then you have diagnosed a solid organ injury. If it is liver, spleen, if there are minimal, a bleed, if the bleed is there, then if you think they are not actively bleeding anymore, okay, if it is about 500 to 1000 ml of blood in your intraabdominal cavity, and nothing is found in your liver laceration of only about 10% to 20%, spleen also 10% to 30%, you will not really operate on the patient. You will keep the patient in observation because he's lost blood. He's in shock. So what you will do is you will basically create an IV line, monitor the patient in ICU. Oxygen requirement if needed you will give. You will give oxygen requirement if needed you will give, and then you will continuously monitor the case with serial CT scans of the abdomen. Once it becomes stable, patient has regained consciousness, is talking to you. He's talking to you, he's now better, he's able to perceive pain, he's able to tell you what is there. Then you should think that the patient is the patient has settled, and you have to observe the patient. This observation will be up to 48 hours. Sometimes it can go up to 72 hours. 72 hours, and continuous monitoring of the hemoglobin will be needed. Hemoglobin will be needed. If it is solid organ injury, if it is solid organ injury, you can wait. Even if it is a kidney in the retroperitoneum, if it's only a small hematoma or confusion or a small laceration that has not avulsed the renal pelvis, then you can wait. Even if it is a bladder injury, there's no option but you have to open. Viscous, any viscous, that is a hollow organ, if there is a damage, no option but you open. And what is the incision that you choose? It is midline incision, midline laparotomy incision you will choose. And then, depending, these days people are doing what you call as a diagnostic laparoscopy. But when hemoperitoneum is there, about 1500 ml of hemoperitoneum, okay, 1500 ml of hemoperitoneum, it is not advisable because you will not be able to see anything. So no diagnostic diagnostic laparoscopy. What you will do is you will do a midline laparotomy incision. If it is a small bowel injury, if it is a colonic injury, if it is bladder injury, no option but you open. Why? Because the abdominal contents will spill and cause fecal peritonitis, or if it is a large intestine, to cause fecal peritonitis. If it is small intestine, you will have all the abdominal, small intestine contents leak, and that will cause problem. That will cause peritonitis, purulent peritonitis or fecal peritonitis, which is not a good thing. That's the reason we open up. And if urine is getting extravasated, then there is an injury to the bladder, so you will have no option. So that is the reason what you should do is you should have a high degree suspicion, especially these three areas: bowel, bowel, large bowel, small bowel, viscous, anything that is called. And once you do the diagnostic peritoneal lavage, you will check for first hemoglobin, not first blood. No, it is blood. So first you will check BCs, you check for the WBCs, and you will check for the amylase. If amylase is detected in your diagnostic peritoneal lavage, it indicates that either the pancreas is injured or the common bile duct is injured. Sometimes liver also, when injured, can cause release of bile. So that will have serum amylase. Serum amylase. So this is how you should understand. So once the patient is there, you will give him oxygen. If it is hollow viscous perforation, you will open up. You will give a thorough wash and then suture the hollow viscous perforation. If it is a large perforation of greater than 1 centimeter, people usually say greater than 2 centimeters, you will have to do a resection anastomosis. If it is a small perforation, you will close the perforation. In the primary sitting, and then wherever the bleeder is there, you will catch the bleeder, you will ligate it, and then you give a thorough wash. You'll put 2 drains, one in the pelvis and one in the Morrison's pouch, and then you close the wound in layers. Whereas when it is a bladder injury, you should do a triple layer closure of the bladder. And the suture material used for all these is vicryl. Vicryl is used for bowel closure, hollow viscous closure, as well as bladder closure. You will use vicryl. And for closing the abdomen, you will either use a polypropylene or proline, or you will use nylon, also called as ethylone. These are the suture materials that you will use to close the rectus sheath. And skin can be closed with various this thing. You can use a proline for the skin. You can use not catgut. You can use monocryl for the skin. You can use um, nylon for the skin. You can use silk for the skin. But for abdominal wall, either you use polydioxanone, PDS. PDS also is the suture material of choice for repairing the bile duct. PDS also is the suture material you use for the repair of bile duct. The repair of bile duct. Then PDS, that is also that is polydioxanone. Vicryl is used for your bladder as well as your hollow viscous. Hollow viscous bladder you use vicryl. Then you will suture and then you put two drains, that is called as abdominal drains, one in the Morrison's pouch and one in the pelvis, and then close the wound in layers. Because there is contact, because it's a hollow viscous perforation that has got infected. So what is the type of wound? It is a contaminated wound. It is a contaminated wound. It is bile duct and others injured, then it will become a dirty wound. It will become a dirty wound. But it is here, it is a contaminated wound, not a dirty wound, because we're opening it up at the earliest. Once the pus has necrotic tissue has set in, then it will become a dirty wound. Dirty wound. So what is the type of abdominal injury wound? It is mostly contaminated wound. What is the type of wound when you do a thyroid surgery, hernia surgery, hemorrhoid surgery? It is a clean wound. Appendicitis is a clean contaminated wound. Appendicitis is a clean contaminated wound. Appendicular perforation is a contaminated wound. In fact, it can be dirty wound. It can be classified in dirty wound. Small viscous perforation, initially if you do it early, when it is only in the bile and all that state, then it is if it is in that state, it is contaminated wound. But once the fecus and the peritoneal pus is there in the peritoneum, it becomes dirty wound. So then you will close the wound. You have to start the patient on a broad spectrum antibiotics. Blood, wherever required, has to be given. If he has lost 2000 ml blood, that is about 40%, right? 40% blood, what do? We transfuse. Ideally, previously it was PRBC was thought to be a superior blood product to be transfused, but now that has changed. Instead of PRBC, it's the whole blood that we want to give, because it basically expands the plasma also. So you give the patient blood transfusion, you will keep the patient on IV fluids, and you have to keep the patient on NPO, nil per oral, and then there should be a nasogastric tube aspiration from the patient. And once all this is done and the patient is mobilized, fast flatus or fast stool, then you can start the patient with food. What is the day when you will see a fistula? I mean, you have done a resection anastomosis and the wound has given up. Which day you will see that? You will see that on the fifth day. On the fifth day. Anything after fifth day, if the pus is there, it is surgical site infection. So with all this, the patient once he settles, then you will shift into the ward. You will give him feeds. You will give him all the other things and see. So primary within 24 hours, if the bleeding occurs, it's a reactionary hemorrhage. If it occurs 7 to 14 days, it's secondary hemorrhage. These are also entrance questions. And the best indicator of improved resuscitation is urine output. If you have resuscitated well, and if the urine output increases, the patient becomes better. Yes. And I told you, in solid organ injuries, if the patient is deteriorating, you will open the abdomen. You will see if it is clean. Probably you will do a partial splenectomy or a total splenectomy. Okay, you will do a partial splenectomy or a total splenectomy if it is clean. If it is if it is liver, you will pack. Okay, to control the bleeding, you will pack. You can't do a hepatectomy. If you do the hepatectomy, patient will die. So we have no option of doing a hepatectomy. So you have to preserve the liver. So if it is bleeding, you will pack it, and you will do a laparostomy. You don't do a laparotomy, because laparostomy you will put a mesh or anything, or a bag and open and keep, and then once the thing settles, you'll have to remove the pack and then close it. It's like that. That's the reason you will do a laparostomy. You will not do a laparotomy. I mean, this is getting on the nerves. The fan comes and goes, the light comes and goes. It's getting irritating. We will deal all these in the next class again. Okay. All these I may not touch in the next class, but next classes we will go in more detail. Thank you.